You're listening to Solihull Radio.
So good evening. My name's Oliver Denton. I'm one of the GPs and doctors that work here at Daleswood Health. We do a series of talks. We try and host one every month. And this month is about back pain, in particular low back pain. Back pain can be everything from the top of your neck or bottom of your neck to the bottom of your bum. And we're very fortunate to collaborate with Spire Parkway and get specialists to come and help me explain about the topics that we're talking about. So tonight is back pain. Let me just move on slides. Why are we doing these talks? Well, it's an opportunity for you to ask questions of us, GPs or specialists. Certainly within the NHS, it's often very difficult to get as much information as you need or want to out of a 10-minute consultation. There's lots of different agendas in the room. The GP wants you in and out fairly quickly because the next patient, you want to understand what's going on, and often you don't have an opportunity to ask very important questions about what's going on, what are my options, and how can I get better. So these series of talks are to give you an opportunity to ask questions and to learn more about your health. I embrace my patients knowing more about their condition than I do. I challenge them to know more about their condition than I do. After all, you're the expert of your body. I'm just trying to work out what's going on with your body, but you know what's going on from a symptom point of view, from an experience point of view, and I have to try and translate that. So it's an opportunity for you to learn more about it, about your body and your problems, and for us to try and explain that in a way that you understand. And that's becoming an expert patient. So, yeah, I would expect my patients with rare or complicated conditions to know more than I do. But the advantage I have working privately is that I have the opportunity and time to really understand my patients and those conditions. But I would like you all to become expert patients in any condition that you have. And allowing you to engage with doctors. Sometimes people feel intimidated when they come into the room, or that they can't ask questions, and that really, I hate that, or the feeling that might be the case. So I really want patients to engage with us and to not feel that there's any divide. It's a bit like speaking to a friend. If you've got a problem, we just happen to be experts, or try to be experts in that condition. So that's Daleswood Health Talks. So, as I mentioned, we're in collaboration with Spire Parkway, and we're fortunate enough this evening to have Mr. Spencer Harland. He is a spinal neurosurgeon, so that is one endpoint to back pain. I hope it never happens to be that endpoint, but Mr. Harland is incredibly experienced and one of the perhaps the only person I refer to locally. Works primarily within the NHS at UHB, so that's the QE. Trained at UCL, did his neurosurgical training both in London and Cambridge. Was awarded the Royal College of Surgeons prize, the Norman Dot Medal, for excellence in his exit exams in neurosurgery. So incredibly experienced, has been working locally for many years, and is a great resource, and we're very lucky to have him this evening. So why back pain? Well, we've picked lots of common topics, but back pain's really, really, really important. And I've just put some key figures on here. It's estimated that 31 million days of work are lost as a result of back pain. So a huge, huge amount of impact. Financially, that's massive. About 40% of work absence is thought to be related to back pain. That equates to about £10 billion to the UK economy. These are all rough estimates. And of that, it's actually felt that 35% of that expense is paid for by individuals privately, so it's not even incurred by the NHS. So a fairly large proportion is dealt with privately, be that physiotherapy or chiropractors or private surgery. But certainly private therapy is an incredibly significant proportion of that cost. I'm going to quickly finish up. This is my last slide, but it's a fairly useful slide because often when a patient comes to see a GP, they've had pretty nasty pain for a long period of time, or have suddenly had very sharp pain that's completely debilitated them. And often they're asking, well, what's wrong? And it's a bit like having proof. If you've had a scan, then it sort of proves how bad it is. But the problem with scans are that they often bring up things that aren't relevant. And this slide really emphasizes that. So this is from a research paper where they took a whole group of normal people, don't have any problems with their back at all. And they looked at the amount of findings per age group. So on the left-hand side of this chart, we have age 20, 30, and decades down to 80. And on the bottom, we have the percentage of patients with that abnormality. And it looks pretty, and there's lots of colours. But the ones really that you're looking at are perhaps the green, which is facet degeneration. So that's the joints between each of your spines that wear out, a bit like arthritis in any other joint. And you can see in your 20s it's pretty low. But by the time you're in your 80s, it's about 80% of 80-year-olds will have wear in those joints, which you kind of expect in your 80s. You're expecting a bit of arthritis, perhaps. The one that surprises me most is disc degeneration. That's in red on this chart, and you can see it's about 30% in your 20s. So 30% of people with no back problems at all that go through a scanner have disc degeneration. So when you get your report after you've had an MRI or any other form of imaging and it says, I've got disc degeneration, I knew it. But actually, it might not be causing your symptoms at all. And of course, that goes to almost 100% in the 80-year-olds. But you hit 50% at 30. So half the people at 30 years old have got disc degeneration. And we're all over 30 in this room. So there's going to be a large number of us, the majority of us, that have got changes that are on imaging. So whilst imaging is very important, it's not always the answer, and it's not very helpful for a doctor to have imaging. What we rely upon is what you're telling us and the symptoms and signs that you have. So we focus very much on the pain that you have and the neurology, and by that we mean loss of power, loss of sensation, pins and needles, the things that we assess when we examine you. But primarily, it's what you tell us. So the most important thing that I find when I'm seeing patients is taking a really detailed and thorough history, understanding what happened, how much it's impacting on that individual, and what the triggers are. And that helps me, in the majority of cases, work out what the problem is and make that decision as to whether, actually, is this something that the neurosurgeons are going to want to see? And if they are, then they're probably going to want an MRI scan. In fact, I won't say probably, I'd say 100% they're going to want an MRI scan to make that definitive decision. But I'll leave that to Mr. Harland. Yes, question already.
Just ask a question. Sorry to interrupt.
No, of course.
Am I right in saying, but sorry, go back 2 steps. The percentages that you show on those bar charts,
Yep.
Actually, let's say the 80-year-old group,
Yes.
that far exceeds the 100%. So I presume
They have multiple pathologies, yes.
Exactly. There's
Yeah.
overlap.
Each one of those colours is a different process that you're seeing and assessing on a scan. So just sort of looking through this, a disc bulge is not a disc protrusion. Disc degeneration is wear within the discs. Facet degeneration is issues within the joints between the vertebra. So each of those are different. So yes, you can have multiple problems. And as you can see, if you're 80, you're definitely over 100. You're probably 400%. Well, not quite, but even in your 40s, you can see that 100% of 40-year-olds are going to have some abnormality on their scan with no symptoms and no problems and no back pain at all. And actually, you could say that for 30-year-olds if we add up those individual bars. Right, so that's all I'm going to say. And now I'm going to hand over to Spencer Harland, who has a talk. So I've just got to switch over the laptops, and he can carry on, and I'll be pressing buttons for Spencer.
Thank you very much for the invitation, Ollie, to come and chat this evening. As you've heard, I'm a spinal surgeon. I started the QE 21 years ago. At the time, most neurosurgeons covered the head and all of the spine. I'd always had a particular interest in the spine, and so when I started, I was fortunate. One of my colleagues there wasn't so interested in the spine and was happy to take on my patients with head-related problems, and I took on his patients with spine-related problems. So for the last 21 years, unusually, I've been dealing just with spinal problems, as Ollie said, starting here and going down to here. But today I'm going to focus on the lower part of the back because that is the area that causes the greatest number of people the most problems. No, so if you could just go back 1 second. My talk is slightly tongue-in-cheek, and I hope you'll appreciate that. But I've low back pain and sciatica, the truth behind the Daily Mail headlines. Now, Ollie's mentioned about the Parkway, and I work at Spire Parkway on a Tuesday. I don't know whether there are any Daily Mail readers here, but on the Tuesday in the Daily Mail, they have their 16-page good health section, and it's absolutely jam-packed of interesting information about health. And what I could guarantee on a Tuesday morning is that I'd be in my clinic, which I started at 8 o'clock, and by 10:30, 11 o'clock, someone would reach into their bag and they'd pulled out a page from the Daily Mail asking me whether they'd had this particular problem. And so, Ollie, if you would, so they would say, oh, well, I've got this back pain and I've seen this on this called an iJoy Ride. It was an interesting name. And whether this would be helpful for their back pain. I said, well, I have absolutely no idea. I would say my wife did buy one of these, but our children and their friends particularly enjoy when they come round in the evenings. But I don't know about that. Another one if we could. Then another patient who had had problems with their back for about 6 months, low back pain, came in clutching the piece of paper or the headline from the Daily Mail saying they wondered if they'd had a stroke in their spine. And I was able to reassure them I felt that was extremely unlikely they had a stroke in their spine. And we see them very rarely. It's a very unusual phenomenon. Then they have articles about having surgery on your spine whilst you're awake. Well, to date, I haven't met anybody who wants to be awake whilst they're having their spine operated. Most people's concern is to make sure they're completely asleep and they don't know anything about it and they just wake up and everything will be fine at the end. The latest thing is talking about minimally invasive surgery, and MIS, or minimally invasive spinal surgery, is a real drive to trying to do operations through smaller holes with smaller scars. One of the problems with the newspapers is they tend to, and the internet, tend to portray this is that we can do things that we didn't used to be able to do before. Well, nothing really could be further from the truth. What we can do with the same operations through slightly smaller holes with a little less pain and patients going home slightly more quickly. But it really hasn't changed the indications for surgery. So you have to have the right symptoms, the right MRI scan, and then an operation may be appropriate, perhaps through a smaller hole. But it isn't that it's transformed spinal surgery for the majority of patients. Of course, nothing more interesting the Daily Mail likes than to have a celebrity with a spinal problem to keep them going. I think we've been recording, I might have to edit this bit out, but as those of you who probably spotted the pictures down in the right-hand corner, it was, of course, whilst searching for pictures of Pamela Anderson that I came across these cuttings. But if you go on. And I think many doctors feel that this is the current situation we find themselves in, because many patients have had a good look through the internet and they come along to see us asking whether we agree with their diagnosis. If you carry on. But actually, some of what out of there, and I must be fair to the papers, is very useful. And one of the big issues, which I'll touch on further in this talk for patients, is identifying those patients that come along with low back pain that have more to their low back pain than just a pulled muscle, a bulging disc, an irritated facet joint. And one of the issues that all of us are very keen to pick up on is whether you have pressure on the nerve to your legs, and Ollie mentioned about neurology earlier, whether you have weakness and numbness. But one of the real crucial things is that if you have a slip disc, and I'll show you some pictures in a moment, in a particular place, they can cause problems with pressure on the nerve to your bladder and bowel. And that can, if not picked up promptly and treated promptly, lead to long-term problems with bladder and bowel incontinence and erectile disturbance. And so this is something that is very important. It's important that patients are aware. The vast majority of patients that will come to myself or Ollie or Kate is going to speak afterwards with any bladder or bowel issues won't have anything that's terribly serious, but it's very important that we pick up those patients that do. As Ollie's already commented on, back pain is a major issue. On here you'll see that there's this is something called disability adjusted life years. So this is how much trouble back pain gives you. And the figure out of 100,000 is 2,300. And if you take all of the other hips and knee problems, add them with depression, add them with diabetes, which fills the papers at the moment, then that won't add up to the amount of trouble that low back pain causes the general population. This is a very interesting scan, and this is a curve showing the amount of time lost from work per year. The x-axis, the bottom axis, is the year, and the left axis, the y-axis, is how many days. And you can see since the 1950s up to the 1990s, there's been an exponential increase in the amount of time lost from work as a result of back pain every year. This is clearly not caused by there being lots more back pain around, because I'm sure there was lots of back pain in the 1950s, but more people's understanding that if they might not have to work, the welfare state, and so it may be easier for them not to work when they have back pain. And this is a very important slide, and that is the longer you are off work with back pain, the less likely it is that you'll ever go back to work. So if you've been off work for 1 year with back pain, there's only about a 25% chance you'll ever go back to work again. If you've been off for 2 years with low back pain, there's only about a 10% chance you'll go back. So there's been a real drive in recent years, although working in the NHS it perhaps doesn't always appear that way, but there's been a real drive in order to try and treat patients acutely, particularly those that appear to be at greatest risk of being chronic low back pain sufferers. And so lots of people have looked into it. Lots of clever people have written guidelines. Ollie's Royal College of General Practitioners have written guidelines. On to the next one. This is fairly quick. NICE, the National Institute of Clinical Excellence, onto that, they've written guidelines. Commissioners have written guidelines. NICE have been back to it and they've rewritten their guidelines. And they produce these very helpful, simple algorithms as to what to do. But in fact, these algorithms are more straightforward than they appear. The main thing is that physiotherapists, once triaged by their GP or triaged by the physios, form the main core of the treatment and management of patients. There are occasional arrows going off for something called red flags, which I'll come on to. So these are patients that you need to be worried they may have something more sinister going on. Those that have sciatica with pain going all of the way down their leg, and the rest of it is about the management of patients with low back pain, which Kate is going to touch on later on. There have been a further update on this, and this is only one of 2 pages of the number of people involved in producing the next document I'm going to show you. And I think, slightly sceptically, I could say the progress they've made here is A, it's in colour, whereas the other one was in black and white, and if Ollie just goes forward one, there are 2 pages rather than 1 page, but if you might just go back for 1 second. But again, the blue areas here are to do with the physiotherapists, and physiotherapists are the main triagers, and by that we mean they're the people, in addition to the general practitioners, who direct patients' care, and they try to do the filtering and identifying of those patients that have something more worrying going on other than the low back pain that most of us will suffer with at some time in our lives. Sorry, if you wouldn't mind just going back 1 second. Again, this has on here talking about leg pain and also what's called the red flags, which again I'll touch on. So if you wouldn't mind going on, and on one more. Red flags are something that we're all, as doctors and physiotherapists, encouraged to be aware of. These are the things that might make you think, if a patient has low back pain, that there's more to this than they've just pulled a muscle or irritated their back. So patients that might have had a recent car crash, for example, a number of you may have been along to your local A&E department after a car crash, reassured there was nothing to do and sent on your way. And so if you're seeing your general practitioner a week later, they might want to re-x-ray you, for example, to check there's something going on. minor trauma, and in with an aging population, sometimes just lifting up some books or leaning over, and you can have sudden onset of pain, and that can be due to a fracture as a result of underlying osteoporosis. It doesn't have to be a major event. Young patients and old patients with back pain is more concerning. If you're middle-aged, lots of patients have low back pain. It's very common, but it's less of a concern. And then, of course, you have the patients who have past histories. If you've had a cancer or malignancy elsewhere and you have back pain, I think many of you in the room would be aware that might be something you would worry about. I suspect some of these things don't worry the patients of this part of the world, but IV drug abuse, we see a lot of at the queue with patients that develop infections in their bones as a result of that, HIV, immunosuppression, and patients that take steroids for long periods of time, not just short bursts, but long periods of time, their bones become weaker and they're more prone to developing fractures. The very bottom here, I won't go into some of the other things, but the very bottom here is this one which says where the patient has symptoms, back pain with saddle anesthesia or recent difficulty with their bladder or bowel function. And when we say saddle anesthesia, we mean numbness or pins and needles in the bit of your anatomy that goes onto a saddle. And I'll show you that in a moment. This doesn't necessarily project that well, but this is an MRI scan of the spine. I don't know whether we can just turn that light down slightly, because I have got a few MRI scans which... Oh, perfect. Hopefully that's not too soporific for everybody, but that's good. And this is an MRI scan of a patient through between their shoulder blades and lower down. You might just leave it off for the moment, Ollie, actually, if you wouldn't mind. That's fine, because I've got a few pictures coming up. And on here you can see the normal shape of a vertebra, and you can see that this one looks wedge-shaped, and that's a bone that's previously fractured, and it looks the same shade as the other bones because the fracture's healed. But you can see this one is a new fracture because it's a slightly different shape, but it shines up, it's bruised or inflamed, and we can tell the difference between old fractures and new fractures. And this is a patient with osteoporosis who fractured a bone at some time in the past and got better, and they have a new pain, which is here. And this is the very lower part of the back through what's called the sacrum. And again, you can see the bruising in the bones either side, and occasionally you can develop fractures there. So if that's old patients, the other end of the spectrum, if any of you have any very sporty teenagers, then it's very common for teenagers to develop low back pain. Now, if you're sporty, one of the things that sporty teenagers are at risk of is developing a stress fracture in their back. We've all heard of shin splints. Well, the back equivalent of that is called this stress fracture. And in the lower part of the back, you can see this white area here. And on the cut in half in the magic show, you can see this white area here. And this is as a result, particularly in tennis players and gymnasts and jumping in the line out playing rugby, that repeated extension of the back can bruise the bones and give rise to these sorts of problems. So if you have a sporty teenager with back pain, it's often worth getting an MRI scan at an early stage just to confirm or refute whether that's the problem. Very occasionally, when you do have these red flags and you have histories of cancer, we find some nasty things on scans, but the vast majority of patients do not have these. And it's Ollie's job and Kate's job and my job to direct you as to whether we think you have anything worrying. But sometimes you can have bones collapsing because of tumours. Certainly in Birmingham we see infections of the spine with tuberculosis. So you can see this vertebra that's collapsing with infection. Sometimes there's inflammation, and that one we'll just leave for the moment. But just, so this is the patient that the Daily Mail was talking about earlier. And this is, if you just go on to the next scan, please, this is the symptom or syndrome called Cauda-Equina syndrome. And this is if you have back pain, usually with pain in your leg, you can develop numbness around your buttock cheeks and your genital areas, the bits that would touch the saddle of either on a horse or on your bicycle. And those areas, the numbness, it also relates to the sensation and control of your bladder and bowel function. So if you have terrible back pain, usually with leg pain, and you do have numbness in that area or problems with your bladder or bowel control, then that's something you should seek immediate attention about, either same day at your GP or to go to an A&E department. A&E department see lots of patients like this. about 15% of patients that go to A&E saying they've got back pain and bladder problems have an MRI scan that shows, if you go on to the next scan, shows they have a problem like this. It's a bit dark on the pictures, but you can see the bones of the back, the spinal cord coming down here, and you can see this big slip disc pressing on the nerves that go to the bladder and bowel. Now, an A&E department will expect about 15% of the scans to be positive. They'll expect 85% of the scans to be negative. But we'd much rather have 85% of the scans negative than miss the 15% of the scans that were positive. So if you have concerns about that, either your GP, your physio, or take yourself to A&E to be checked out. So that was kind of an overall summary. Just specifically on particular areas, patients present with low back pain, or they present with sciatica, or something called claudication, which we'll come on to a bit later on. Low back pain, and let's roll on. There are lots of causes of low back pain, but the vast majority of patients have wear and tear or degenerative changes in the back. As Ollie was alluding to earlier, we have what's called a motion segment. You have one vertebra and another vertebra, and they have the disc in between. And there are some joints in the back which help everything maintain the alignment. As everything begins to wear and things move, then everything tends to begin to wear out. The disc wears out and bulges, the facet joints wear out, the ligaments wear out, and that's why in Ollie's slide, once one thing starts to go, then everything starts to go, so you get different things occurring at different ages. Carry on. And once more. Now, these are sort of cadaveric pictures, so they're rather gory. I hope you don't mind these pictures. But the picture on the left-hand side is effectively a cut of a back that's completely pristine. You can see nice, big, juicy, healthy discs. And you can see this scan over here, or this cut over here, which is from an elderly patient. You can see how the discs have narrowed. You can see how the discs are bulging at the back and the spine started to lean forwards. Now, we often see patients with effectively scans on the left-hand side who have back pain, despite their back looking very good. And Ollie and I, and I'm sure perhaps some of you in the room, will have backs which show quite a lot of wear and tear on scanning, but actually isn't causing you any problems at all. And that is one of the difficulties with interpreting MRI scans. Most people with back pain don't need any investigations. Well, Kate will be talking in a moment about what's needed. If your GP is concerned, they might want to run a few blood tests just to make sure there isn't anything more concerning going on. There are different things to do. We very rarely use x-rays now. If you've had an accident, yes, an x-ray may be useful. CT scans are very rarely required, but a surgeon may arrange that. MRI scans we'll be looking at in a moment. And DEXA scans, has everybody here heard of a DEXA scan? A DEXA scan is a bone density scan. It shows you how strong your bones are, particularly for ladies when they become more senior. And that's a scan which is increasingly useful because with an aging population, if you do have osteoporosis, particularly if you've had one fracture from a fall, then we can give you medication which strengthens your bones and improves the bone density going forwards. So if you have back pain, what are the options? Well, analgesic, it's become increasingly difficult with analgesics. Excuse me. For most patients, taking an anti-inflammatory, providing they don't have a contraindication to that, perhaps with some paracetamol, can be worthwhile. In the past, there's been a lot of patients being prescribed codeine, but there's a feeling that we're perhaps over-prescribing codeine and a drive to reduce that. Stronger painkillers are not recommended, and if they are used, they tend to be just used in the short term. Many years ago, you would have heard about people lying they used to take the door off of the hinges and lie on the door for days or weeks at a time. We found that wasn't such a good idea because some patients found after a week or two they quite liked lying on the door and not doing very much, and their partner bringing them cups of tea and breakfast and things like that. So the mantra now is get up, keep moving, keep mobile, that although you may have pain, you're not doing yourself any great harm by keeping as mobile as possible within reason. Physical therapy is undoubtedly the mainstay of treatment for low back pain, whether that be physio or chiropractic. And at that stage, I'll stop and let Kate have a chat, and I'll come back and talk about some of the more invasive things I perhaps do a bit later on. That's okay?
Right, I don't know if you can read that or see the picture anyway. Physios do have a little bit of a reputation for being physio-terrorists, but I think that physio is taking things a bit far. Hi, my name's Kate. I'm one of the physios here at Daleswood, along with my colleague Karen, who's just at the back there. So we are both musculoskeletal physios, which basically means we can assess or treat any injury or pain that's coming from the musculoskeletal system. So essentially that umbrella term means muscles, bones, joints, ligaments, tendons, so any of the above. So that means we can work from anything from here right down to the toes, but obviously we're going to focus on back pain today. So my first question is, I'm assuming that everybody's here because they've either had back pain or they've got back pain or they know somebody that's got back pain, but we haven't actually asked you. So I'm not going to ask anyone individually, but if you wouldn't mind, could I just have a show of hands of who's had back pain at least once? Okay, so not everybody. Okay, thank you. And I have too. And has anyone got back pain now, sitting here right now? Okay, so a few. Could I ask who's had physio in this room for back pain? Ah, a few. Yeah, okay. And the next one might be a bit tricky. Can I ask who had benefit from physio for their back pain? Are we getting any hands? Oh, we've got a few hands, that's good. Phew. That's a big relief. Right, okay, good start. Right, okay, so what I'm going to talk about first of all, these are the three main things I'm going to be talking about. So first of all, when to see a physio for low back pain and why. So obviously Spencer was just talking about many of the things that can cause back pain, and really it's when a lot of people don't know, do I go and see my GP, do I go and see a physio, do I go and see a chiropractor, do I go and get an x-ray, do I go and get a scan? So obviously we've touched on that a little bit, but I'm going to go into that a little bit more. The second thing I'm going to talk about is what does physiotherapy involve. So some of you have already had physio, so you know what to expect. Some of you haven't, so I'm just going to talk a little bit about what you would expect from a physio session if you were to have one. And then just to finish, I'm going to talk a little bit about self-help and prevention of low back pain. So, just very briefly to reiterate, the bad news when it comes to back pain is that it is pretty prevalent, as Ollie and Spencer just said. So, approximately 60% of the adult population suffer with low back pain, so that's quite substantial. And the disability from low back pain has increased over 50% since 1990, which seems huge. And I think one aspect of that is possibly bringing in things like the computer generation, but it's not solely that. I think life expectancy comes in there as well. The good news is, as Spencer just said, serious pathology, nasty things that might be going on with the spine are really quite infrequent. So, you know, that's something to definitely take comfort from. Things like your spinal fractures, your infections, your inflammatory arthritis, nasty growths, etc., etc. So, you know, take some comfort in that. A small percentage of low back pain becomes chronic, and that's also quite positive. So when we talk about chronic back pain, we divide it into three areas. We've got your acute back pain, which is anything less than 4 weeks. We've got your subacute, which is 4 weeks to 12 weeks, and chronic is anything beyond that. So actually the percentage of people whose back pain goes into that is perhaps smaller than we think. Then 90% of people with low back pain will recover in 3 to 4 months with absolutely no treatment at all, which I probably shouldn't be saying because I'm a physio and obviously we want to make sure we get you better. 70% of people with low back pain will recover in a month with no treatment whatsoever. So do we need physio if that's the case, if we're just going to recover ourselves anyway? Yes, we do. Of course we do. Because the evidence suggests that early treatment intervention, whether that is physio or potentially chiropractic treatment, does result in a faster recovery rate. So if you're getting better quicker, you're less likely to go into that chronic stage of back pain, which is what we don't want to if we can avoid it, because it just becomes a bit more complicated to treat. So absolutely, getting in there and getting some treatment fairly quickly is important. It's also been found that the reoccurrence of low back pain is really quite high. So if you've had back pain before, there's a 60% chance that it might return. So in this room, who's had more than one episode of back pain? Okay, so a few of you. Yeah. So, and often that can reoccur within 3 to 6 months. So that could be quite quickly afterwards. And in fact, and I'm sure Karen will say the same, quite commonly from a physio point of view, we will see people who perhaps have had back pain before, didn't do anything about it, got a bit better, so it was fine, felt fine, and then it came back again. You thought, oh, well, it sorted itself out last time, it's fine, and then it doesn't, and that's when they come and see us. So the sooner you can get in, the better. When do we see a physio for lower back pain and why? Definitely the sooner rather than later. So getting in there early, not only can it get you better quicker, but it can improve your clinical outcome, less likely to get into that chronic stage. And as Ollie touched on before, it's more cost effective as well. Less visits to GPs, less scans and things like that. Just go back to that. Just one quick study there that the British Medical Journal showed, and it is one study, but it did find that if GPs can refer patients with lower back pain to physio within 2 weeks of onset, so 2 weeks after the back pain starts or less than, they are half as likely to end up needing surgery or injections in the spine. And again, plus it reduces costs. So that's fine, thank you. We'll move on. So why would you choose to see a physio for lower back pain? So according to the CSP, which is the Chartered Society of Physio, our role is basically to treat people with injury, illness, disability, and we use that form of treatment would be movement, exercise, manual therapy, education and advice. Now, in terms of how we approach back pain, physios use a whole person approach. So we're not just getting the patient in the room, saying, where's your back pain, manipulating their spine, saying, see you later, hope that feels better soon. We are looking at all sorts of things. So 3 main things, really. We are looking at the mechanical factors. So when we assess them, after we've asked you lots of questions, we will look at the body, look at muscle weakness, strength, joint stiffness, posture, all sorts of things we're looking at to see what's going on with the body. But we must also take into effect things like psychological factors. So are you stressed? Are you anxious? Are you afraid to move? Because there's absolutely no point in us trying to mobilise your spine and get you better if you are just so stressed that tension is permanently there and you're coming back week after week and we're just correcting the same thing again and again. So it's important that we consider that, and it's pretty common thing as well. And then social factors. So again, there's no point in just manipulating your spine and doing some treatment and sending you off. If you are in a work environment that is very repetitive in nature, or you're sitting in a terrible setup for 8 hours of the day, coming to us, we're doing a bit of treatment, feeling great, and then you're back there another 8 to 10 hours of the day. We've got to consider all those sorts of things. Lifestyle, what are you doing every day? Are you doing the weeding like my mum, like this, for 2 hours and then wondering why your back's a bit stiff afterwards? So we've got to look at all of that. Sports, if you're playing golf 3 times a week, your spine's doing the same thing over and over again. We've got to look at that, and we're not saying you've got to stop all these things, but we can help you look at how you're doing it, looking at the techniques, looking at your positions, and trying to help you with all of that. So it's that whole person approach. And really, once we've done that, our main aim is to restore your movement and your function and get you back to what you want to be doing. Okay, ideally, that's the ideal goal. So just a sort of quick almost recap there. So physio, we can help diagnose the type of low back pain that you've got, identify the impairments, again, looking at your mechanical, social factors, psychological factors. We use an evidence-based treatment approach. So Spencer mentioned the NICE guidelines earlier on. So they're basically guidelines based on the best available clinical evidence that we've got. And the NICE guidelines at the moment, from a therapeutic point of view, non-invasive point of view, definitely advocates the type of approach that we use. It includes manual treatment, but it definitely includes exercise as well. And that's what it really encourages, is whatever we do, hands-on wise, again, whether you saw a chiropractor, an osteopath or a physio, there needs to be an exercise element of it, because that's the most successful outcome you're going to get. And also just the reduced risk of lower back pain being reoccurring, which again is hugely important. We also have the ability, obviously, to refer back to your GP or refer you to your GP or refer you on to somebody like Spencer to take things a bit further should we think it's necessary. So, what does physiotherapy involve? So some of you have had physio already, so you know what to expect. But for those of you that haven't, the first time you come and see us, generally speaking, it's an hour session because it's an assessment. So again, going back to what Ollie was saying earlier on as well, I generally, in the first session, probably talk more than I look. because if I miss anything the first time, you're almost going a bit blind. And I think there's just so much information to talk about, you know, in terms of how long you've had your back pain, where does it hurt, all sorts of things. And if we miss anything, you're then on a back foot, really, trying to sort of catch up and work out what you should have seen, and you might miss something. So the first session is an hour. We'll ask you lots of questions, then we would look at the body and do various tests. We'd come up with some form of diagnosis after doing those assessments and a treatment plan. And then treatment sessions going on from there would depend partly what we find, but if we feel it's physio appropriate, then we'd either do 30-minute sessions or 45-minute sessions, which again could be a combination of manual treatments and exercise. One of the things that I do here is called the Back Fit program. So prior to working at Daleswood, I used to work at a chiropractic clinic in Solihull. I worked alongside some chiropractors there, which was really good. Went on maternity leave and then came here because this job came up, and it was much closer to home, lots of lovely people and lots of clinicians, which was great. But I learned a lot when I was there, and I set it up while I was there and have brought it over here as well. So basically it involves 6 45-minute sessions. So I would do the initial assessment, make sure you're appropriate to take part in it, but if I think you are, then you would come and have 6 sessions, generally once a week, but it might be spread out as we get further towards the end. And as I said, a combination of manual treatment and exercise with me. So I would work out what your body needs to do. Does it need to strengthen certain bits? Does it need to loosen certain bits? And that's what your exercise program would be geared towards specifically for you. So every time you would come, we would do some exercises together, make sure everything feels okay, and then we would do the manual treatment, loosening what's stiff, etc. after that. And at the beginning and at the end, I do functional tests, looking at all different parts of the body, so that we can see functionally how, you know, have you improved at the end. And obviously the main thing is that you feel you've improved, but that's one of the things we do here. Karen also does a lot of Pilates work as well. So similarly, she will do longer sessions and mix it with a bit of manual treatment, should that be required. So again, the exercise therapy is important there. So, physio assessment. So again, some of this Spencer has already discussed in terms of things that we need to speak to you about before we get started. So I said this is the bit, the subjective assessment is the bit that I spend a lot of time doing at the beginning, asking you lots of questions. So not just where's your pain, let's treat it, but finding out a bit of history. How long have you had it? Have you had treatment before? How does it work? Have you had any scans? The amount of people that might have said, no, I've had no problems before, and then once I'm treating them said, oh, well, I had an MRI scan 10 years ago and I had a prolapsed disc. Oh, right, so you have had some back pain before. So it's just trying to get all that information, finding out what aggravates it, just to help guide us towards what kind of structures might be involved. 24-hour patterns, that's just finding out, again, is it worse in the morning, is it worse in the evening, is it worse when you're moving or worse when you're still? Just, again, to give us a bit of direction of sort of the area, the type of structures we think might be involved. Red flags is the biggie. So definitely, particularly if you come and see a physio privately, I mean, seeing any physio anywhere, they would have to ask these questions. But when you see a physio privately, often you haven't seen a doctor before. So it's very important that we clear all of those questions and make sure there's nothing that would make us worried or warrant further investigations, an MRI scan or seeing a spinal surgeon. So yeah, most of that I've mentioned already before. The main thing there at the bottom is goals. So again, we're not just trying to get you in, manipulate your spine and send you off. We need to know what it is you want to do. Do you want to be able to just go to sleep without discomfort? Do you want to be able to play with your children, your grandchildren? Do you want to be able to play sports? Do you want to be able to do an Ironman next year? So we need to know what we're working towards, and then we can come up with a hypothesis, potential causes, and then that will direct us into what we need to do objectively. So the next stage would be an objective assessment. So again, that picture's come up there again, but we don't generally pull your legs up past your head to see what's going on. But we definitely need to look at your back. So sometimes people are a little bit surprised when they come in, and we ask if they could just take their T-shirt off so we can see their spine. So that's just something to be aware of. Obviously, it's a you know, an area sometimes people are a bit surprised by, but we need to look at your spine. We need to see if there's any deformities, if there's any scoliosis, any curvature of the spine. We need to look at your posture. We need to look at your muscles as well. Is there any spasm anywhere or anything like that? And we can't see that without looking at your back properly. Then we'll have a good look below and above the area of pain. So we'll look at the hips. Your hip movement might affect your lower back. Your thoracic spine further up, your shoulders. So again, sometimes people are a bit surprised when we start looking at their hips, when their pain's up here. But it's also interlinked. We've got to rule things out. Then we'll palpate. So have a little feel down through your spine, feel through your muscles, see how it feels. Is there any tension, trigger points, any stiffness in the joints? Neuro exam. So this is if you present with any pins, needles, tingling, numbness, anything that's referring down into the legs. And that's when we look at your reflexes and your sensation and the power, just to see if there's anything affecting your nerve roots. And then also looking at muscle lengths and strengths. So again, sometimes probably more commonly than not, we see muscle imbalance being the main issue. So if somebody's really repetitive in nature, they're very tight through the front, they're always sitting, or they're always doing lots of walking, then you can get this muscle imbalance, and that can affect the position of your back and your pelvis as well. So we'll be looking at all those things. And then after doing all of that assessment, we come up with a provisional diagnosis. As long as we've ruled out the red flags, then we can formulate a physio treatment plan. Now, before we go any further, does anyone need to stand up? I'm just well aware this is a back pain group, and actually sometimes these chairs are quite uncomfortable, so if you feel you need to have a little stand up and move, please do. Right, so once we've ruled out red flags, we know there's nothing that warrants an MRI scan or seeing a surgeon. We basically call it a non-specific low back pain. That's when we know physio is appropriate. So it's a bit of a funny name, sounds a bit blasé, but that incorporates things like your intervertebral discs, facet joints that have been talked about before, so the joints between the different vertebrae of the spine, muscles, ligaments, fascia, soft tissue, tendons, things like that. So all of that comes under that umbrella term. And essentially for all of that, it's a similar approach. We want to loosen what's tight, we want to strengthen what's weak, and get you working functionally. Okay. So just a quick look at the spine. I'm not going to go into great depths with the anatomy, but if you can just see that profile of the spine, you can see it's a sort of S shape going on there. So your neck naturally curves inwards or forwards, your thoracic spine in the middle curves slightly back, and then the lumbar spine the other way. That sort of S shape. And that's what we sort of call is your neutral spine position. And it's when your spine is not in that position that often problems can arise. So if you just remember that as your neutral spine, because I will be touching on that. But in terms of the lumbar spine, so the bottom part, you can see again, looking at the pictures here, that the vertebral bodies here are a lot fatter and wider than they are further up. And that's because the lumbar spine is taking the load. Every time you lift, bend, put any strain, a lot of it is going through the lumbar spine, which is one of the many reasons why it's the commonest area to get problems in the spine. So I'm going to talk very briefly about this, but just so you can see, that's the shape of one vertebra. So lumpy bits that you feel going up through your spine are the bits at the back, the spinous processes, and you've got all of these going up all the way through from the neck right the way down to the coccyx at the bottom, and you can see the gap in the middle there, so that's a hole, and that's where your spinal cord would go through. And the bits that stick out the side essentially are there for muscles to attach to and ligaments. This is just a picture of a disc. So some of you may already know where your discs are, but just you've got your vertebra all the way down through your spine and your discs sitting in between, squidgy, soft gel-like bit in the middle, firm bit on the outside. Problems arise when the inner bit starts pushing out. Okay. The facet joint, again, we've talked about that before. So they're the two little joints at the top and the bottom of each vertebra, and essentially they glide on each other and allow your spine to move. And that's another area where you sometimes get problems. And then, as you see here, this is the spinal cord going through the canal. You can see it going through the middle. And these are the little spinal nerves, and they come out at every level, going all the way down through the spine. And that's where often, if they get pinched or pressed, it goes down through the body, through the legs, and that's where you can sometimes get that sciatic pain. And this picture is just showing the different spinal levels, and if nerve roots are compressed, where you might feel the back pain. And again, that might just guide us into helping us know which level of your back's the problem. So I touched on this before, muscle imbalance, and I just wanted to show you a little picture because this is something that I am sure Karen deals with a lot. So hip flexors, so muscles that flex your hip, so do that movement bending up or coming down. So we do that a lot when we sit, when we walk, when we run. And essentially what can sometimes happen is these hip flexors, they attach to your lumbar spine They come down through the pelvis, and then they attach to the front of your thigh at the front, and they sit on the inside basin of your pelvis as well. What can often happen is they can get really tight and then shortened. And if you imagine, if they're attached to your lumbar spine and they're tight, they start to pull, and they can pull your lumbar spine into that compressed position. So the more arch you've got on your back, the more concertinaed and compressed your lumbar spine will be. And then the picture on the side there just shows the glute muscles, the bottom muscles. And again, what can sometimes happen is they get longer and weaker. If we're sitting, they get longer, they get weaker. And one of their roles is to help keep that triangular sacral bone down and try and keep that back in a better position. And if they're weak, they're not going to work against the hip flexors, and then you've got this double whammy. So the next picture just shows what can happen if you get tight there and weak there. The back starts going into that more compressed position, and that can press on the nerves. And this just shows some of the core, the deep muscles of the core, which have been very fashionable for quite a few years to work on. We now know that it's not the be-all and end-all, but actually if we can work on a combination of muscles and get motor control good, which means, as I said before, the stiff bits loose and the weak bits tight and strong, not tight, sorry, just strong, then that will help. So you've got your three main muscles there, the transversus, which is like your corset of muscles around the tummy and the spine, the multifidus, which comes up through the back, and then the pelvic floor muscles, which sit underneath from the front to the back, the pubic bone to the coccyx, and then splaying out underneath. So it basically goes all the way around. And that's one of the areas that we like to work on alongside other muscles around the pelvis to try and get stronger, to get stability in your back. So physio treatment, again, I'm going to focus on just briefly those three areas, the acute, the subacute, and the chronic. So the nice guidelines for acute back pain is basically get in and get some advice, first of all. So somebody to look at you and give you advice of what will help your back and what will help your back positions wise, posture-wise, pain relieving wise. And again, as Spencer and Ollie said, encourage normal activity. The highlighted bits are just the bits that the physios or the chiropractors could do. So spinal manipulation is another one, and analgesics should they be required, or muscle relaxants. Moving on to the subacute stage, that 4 to 12 week stage. Again, advice is really important from our point of view, but this is where the active physiotherapy comes in a bit more. So when your back pain's a bit less acute, really getting in there, doing the stretching, the strengthening, the aerobic conditioning, getting moving. The manual therapy now could be including other things like massage, myofascial release, mobilising the spine as well as manipulating. And again, exercise therapy, which is there every time. And then moving on to the chronic stage. So physio is still very much involved in this stage, but this is where it's encouraged that we have an interdisciplinary approach. So not just physio, but it might be there's be some involvement from CBT, so cognitive behavioural therapy, a bit more involvement perhaps from the GP in terms of analgesia, potentially involvement with a surgeon as well. Acupuncture is another thing that's been advocated at this stage, not necessarily in the acute stages. Both Karen and I do acupuncture as well. So that's the sort of the forms of treatment there. I've already mentioned the BackFit programme, so we can skip on from that. How do you see a physio? So obviously two ways. Via the NHS, you can go to your GP. You can mention that you'd like to have some physio sessions, and they can refer you on. Obviously, waiting times do vary, and that depends, where you are and which GP practice you're at. Or you can go privately. The benefits of that are that obviously you can self-refer, so you don't need to go via your GP. You can just take yourself in, make a phone call, and go and see a physio. So you can be seen quickly. So here, for example, you can often be seen in the same day or the next day. It would be self-funding, obviously. It's not via the NHS, but if you've got insurance as well, that's another option. But I would say do your research. So if you're going to go and see somebody in the NHS, obviously they have to be registered and all that sort of thing. Privately, as with any clinician, they should be, but they not always are. So make sure that they're always a member of the CSP, the Chartered Society of Physio, and the HCPC, to prove that they are who they say they are. And that little website there, the CSP, if you Google physio to you, that tells you the local private physios in your postcode area. So that's quite useful. And they will not be on that list unless they are registered. So the last little bit is basically just self-help for low back pain. And it's really reiterating what I've said already. Number one, it's move. Now, obviously, if you're in really nasty acute back pain, it feels like you shouldn't be moving, but all joints like to move, even if it's just a little bit. They don't like being kept still. So moving is key. Regular back stretches and leg stretches are important. Motor control, all about the stability around the core and the glutes and the pelvis, is important, so exercises for that. Pain easing positions, so coming back to the neutral spine, whether you're standing, sitting or lying, just think of that S-shaped curve. So on your side in bed, make sure your pillow height is appropriate, pillow between the knees, sitting, lumbar support, and standing, not hanging on your spine, but trying to keep that S-shaped position. Heat and ice, easy, quick way of giving a bit of relief should it be required. And don't ignore the warning signs. So if you try all of these things and you're still feeling the back is niggling on, seek some help, either your physio or GP. Okay. So key message, get strong, get mobile, get back on track. And should those things not be sufficient, or any red flags are shown, that's when we might refer you on to Spencer Harland, who's just going to come back and briefly talk. Oh, sorry. Yes.
Just one question, sorry. In your experience, what sort of percentage or what fraction of people, younger people especially, suffer with back pain due to, say, poor footwear, poor foot position, or even other structural problems in the legs?
Yeah, that's a good question, actually, and quite a lot, actually. We do actually have a podiatrist here, which is very handy. But, I mean, it's a huge percentage of people with that sort of foot pronation dropping in, and then what tends to happen as a result of the feet dropping in is the legs then rotate in from the hips, and then that brings in a lot of change in the pelvic position, the muscles around the pelvis, and again, the compensation makes you then change your back position. So I would say that's definitely involved. I wouldn't necessarily say as soon as I see someone with a foot position issue, I refer them straight to a podiatrist, because it's a bit of a chicken and egg. So sometimes if you're weak through the glutes, the hips rotate, and that can exacerbate foot pronation. And sometimes if you throw some orthotics straight in the shoes, that can make things feel a bit worse. So I would definitely go down the road of looking at the muscular control first, and if that improves things, great. If it doesn't get us there, then I would refer on to a podiatrist at that point.
Underpronation as well as overpronation, is that the same, or high arches or whatever, is that?
Yeah, I mean, it's all, the biomechanics of the foot position is always going to have an effect further up, and it's more common for people to pronate and things to rotate in, but you can have it the other way, and then again, you're going to have to compensate further up, so you're going to have to compensate at the muscles of the hip.
I went on one of those pressure
like a gauge
sensor things. I think it was a sports soccer.
Oh, right,
I had a spiral fracture of my fibia or something on my right leg. Yeah. And that's the first time I noticed that, according to that, I had a normal arch in my left foot and a high arch in my right foot.
Yeah. And the thing is, when you're asymmetrical like that, then the body is going to try and compensate because it's very clever like that. But there's only so long that you can compensate before little things start to break down sometimes. But often, I mean, I'd say that's the majority of what I see, is compensatory issues. And once you can unravel it, it's often a really, really good one to treat, because if you can deal with those things, then you can get back on track. So, okay. Right, I shall hand it back over to you.
Right, I'm back. Thank you. So, yes, I say it's slightly strange to be talking, because the vast majority of patients with low back pain don't require my input. It's physiotherapy, assessment, and excluding there being anything more concerning. But sometimes things don't work and other options are considered. Kate mentioned acupuncture. Acupuncture can be worthwhile potentially in chronic low back pain. The latest NICE guidelines actually have taken acupuncture out as an option for acute to low back pain. I have to say I've seen quite a few patients that actually have responded quite well to it, but the latest guidelines don't support acupuncture for more acute pain. The latest guidelines are interesting because one can't help but feel that the guidelines are slightly guided by money as well, because they also talk about injections, and there's a real drive in the NHS to stop doctors giving patients injections into their back, which I think is perfectly reasonable because they're not necessarily terribly effective and not necessarily good value for money. But there are some patients who will have pain in their back, often one-sided, particularly if they lean backwards, which is arising from their facet joints. And there is good evidence, which is supported by the NICE guidelines, that if you have an injection of some local anaesthetic and cortisone around one or two of those joints, and your pain is better for a short period of time, it's then possible to have a procedure where you put in a needle, but rather than injecting something, you heat the end of the needle, and that numbs the nerve endings in that area, and that's called a radiofrequency denervation. And the NICE guidelines are actually very supportive of that. What they're very cautious to not to publicise is that you need to have injections to find out whether you were a candidate for that denervation procedure in the first instance. So although they're very negative about injections, you can only get to there if you've tried one of those in the first instance. But I think the take-home message is repeated injections in the back are probably not terribly worthwhile. They may have a role in low back pain if other things have failed. TENS machines, perhaps. Kate's touched on these others. If you Google treatment of back pain, you'll see particularly American radiologists and people in parts of Europe saying that they're offering percutaneous procedures, and they sound very appealing. They're often local anaesthetic or a minor amount of sedation, and you can go home the same day and back to work the following day. But the evidence behind those interventions is very weak, and very few clinicians in the UK undertake those sorts of interventions. And then you'll see right at the very bottom, and I'm specifically talking about low back pain here, right at the very bottom is surgery. Surgery is the last option when you have low back pain. Because it's the last option, it doesn't mean to say it's necessarily an option. The vast majority of patients with low back pain don't need a back operation, and indeed probably wouldn't benefit from an operation. But there are some patients. And low back surgery for back, it's one of those things that I see patients, and many of them say, oh, my uncle had an operation, he hasn't been right since, or this, and a lot of that surgery was actually surgery to try and treat low back pain. And anybody whose uncle had an operation 30, 40 years ago, I'm grateful for their suffering, because we've learned an awful lot by the mistakes of our predecessors. So we now know who actually, or have a better idea who will and who won't. So I just want to show you a patient who might actually be a candidate for an operation to fuse their back for low back pain. And this is someone here, again, it's not the greatest projection, but you can see the vertebra, you see the discs in between. These discs look very nice and healthy, but you can see here the bottom disc in the back is darkened, and you can see there's a slight step there, which Ollie mentioned earlier, which is called a spondylolisthesis. If you have low back pain, it's interfering with your day-to-day activities, you've tried all of the above, you've got rock-solid core, and you still have back pain, an operation to fuse your back, to put some screws and rods in, which I'll show you in a moment, can be very effective. Now, when we first start off as surgeons, with this insertion of screws was something just developed in the 1970s, 1980s. And when you first see these screws going in, which are not so dissimilar to the size of my little finger and perhaps a little longer, they are very substantial. And you think, my goodness, how am I possibly going to get those in the right area and missing the spinal cord and the nerves at the same time? But the idea behind this is that the bone has a solid outer cortical surface, and it has a soft centre, so it's a bit like a crunchy bar with the chocolate on the outside and the honeycomb on the centre. And if you make a hole in the right position on the outside and you put a blunt probe down, you can find your way into the bone. It doesn't want to come out through the hard surface. And so with practice and experience, you can find your way in and then put a screw into that position. And so we have pictures that look a bit like this, where, in fact, this is two screws. They're parallel with each other, but it appears to be one. So two screws in here, two screws in here, and you can see how the screws over there have gone either side of the spine. And we connect them with a rod. It's very good. It gives an instant fix to the back. So in years gone by, patients may have had to lie in bed for weeks or months at a time whilst everything's stuck together. But this, we can put some screws and rods in, and some patients go home the day after the surgery having had this done. This is good, but one of the problems, if we go on to the next picture, is that if you leave discs at the front like this, then sometimes the metal work can fail. And you can see how in this extensive fusion, the rods, despite being very big rods, have broken at the back. So what we've started to do more now is to try and put something at the front where the disc is so that it's supported. And so we put in these things called cages, which are either made of titanium, which is a form of metal, or a plastic, expensive plastic called PEEK. And we put bone graft into the centre, and then we can put those cages into the disc. So if I just show over here, we can see the screws and the rods are here. We've pulled the nerves to one side, put these cages in, filled them with bone, and you can imagine the bone graft will grow across here and form a solid bridge of bone at the front. And the screws and rods after a while actually become superfluous, because once the bones have stuck together, then these are no longer necessary. And you can imagine on here, to put these in, the nerves are running through here. You pull them to one side, put that one in, pull them carefully to the other side and put the other one in. So that has transformed the surgery and improved the stability and the effective fusion that patients will get. This is one of the areas which is definitely developing. I was slightly cautious about minimally invasive surgery earlier, but sometimes it can be helpful, and particularly for trauma and potentially for malignancy. But this is a very clever device. And what we have here is a device that goes all the way through the skin, through the muscles, into the bone, and straight the way through with a screw connected at the end into the vertebra. And then we have another one, which we put into the vertebra below. And you do all of this with X-ray guidance and taking pictures from the front and the side. And then a very clever chap, or lady, came up with this arc. And if you clip these two together and you put this on, and you put a rod, this is your rod, it's geometrically designed that when you deploy this rod, it will go in here and it will go all the way through to the heads of the screws. And so if you show the next picture, Ollie, you can see it's been pushed. So you swing it round, and now that rod is all the way inside the patient, and we can put it into the head of the screws without having to create a big hole in the back with the potential trauma associated with that. And at the same time, through smaller holes, this small hole here, you can go through, you can clear out the disc, and you can put some metal work into the disc space. So this is an operation which is performed minimally invasively, and this rod here has found its way in on the arc into the heads, and then you put locking nuts in the air and fix it all together. It works well. There's concerns about it for just low back pain surgery, because it's perhaps not quite as effective as the old-fashioned operation, albeit that's a bit bigger. The scars are quite good, and patients tend to be fairly happy with them. Now, sciatica, this is the one that's far more likely to be an issue for most of us other than back pain. Sciatica, just to be clear, sciatica is the name given to pain going in the distribution of your sciatic nerve. Your sciatic nerve runs through the buttock, down the leg, either into the front of the shin, the side of the calf, or the back of the calf. You don't have to have pain all of the way down, but quite often patients will, and going into their foot. And sciatica, for most patients, is due to a slipped disc in the back, compressing the nerve and giving them pain in the leg, which we refer to as sciatica. And you can see on here that this disc has protruded out at the back. You can see beautifully the nerves coming down here, and you can imagine the nerves being pinched. On this image over here, we can see the nerve on the right-hand side quite free, and you can see over on the left-hand side the disc bulging and compressing the nerve. Most patients with sciatica, I think as Kate alluded to with back pain, most patients with sciatica get better spontaneously. It can be terrible for a number of weeks, but what tends to happen is that your body, as in the case here, you can see a slipped disc coming up here, and this was the scan 3 months later in the same patient. You can see it's far less obvious. Your body recognises that bit of disc that's come out as being in the wrong place, and rather like a bruise on your thigh, it makes the piece of disc shrivel up and disappear, and the pressure comes off of the nerve and the sciatica gets better. There are a few exceptions. One is the cauda equina syndrome, which I mentioned earlier, and those are the patients where you have numbness down below and problem with your bladder and bowel function, and we want to know about that straight away, as in within a few hours. If you have terrible pain going all the way down both of your legs, it means you're potentially more at risk of having the bladder and bowel problems, because the nerves to your bladder and bowel are in between, and we'd like to know about that relatively early. Some patients with sciatica develop weakness, and the two most common weaknesses is either the ability to stand on your tiptoes, which is a problem normally with the bottom disc of the back, or what's called foot drop, and the best way of testing that is just to see if you can walk around on your heels. It's more difficult to do than you might imagine. But if you're walking around on your heels and you find that one foot is doing that, that's called a foot drop. And if you have that, then you need to see Ollie or Kate at an early stage. And depending on the degree of weakness, you may or may not need to be considered for an early scan and potentially for early surgery. If it's so floppy that when you're walking along you have to lift your foot up because it's hanging down, then we would definitely want to see you straight away. And indeed, if you just went to a local A&E department, they would scan you and hopefully refer you on promptly to be sorted. And then, I don't know here whether someone has had terrible sciatica. When it's bad, it's very bad. Lots of ladies say they'd rather have another baby rather than have sciatica. And if you've had sciatica for a couple of weeks and you're not making any headway, then at least start the referral process. It may get better in the interim, in which case there's nothing more to do. This is the patient with the cord recliner, the pressure on the nerves, the bladder and bowel. So the treatment of it, painkillers, lots of patients say they don't make any difference, and GPs say, well, I've given you the strongest version of this anti-inflammatory and thing, but often they don't make a great deal of difference, so don't be too disappointed, well, you'd be disappointed, but don't be too surprised if tablets don't make a difference. Physical therapy can be of assistance, to assess you, support you, but for most patients, the getting better of the sciatica is about doing this and giving it time. On to the next one. Oh, sorry, just to go back one more. If you're not settling, and you've tried the physio, you've tried the painkillers, an injection here can be very worthwhile. So an injection of some local anaesthetic and cortisone around the nerves in your back, either an epidural, in the way that a pregnant mum would have an epidural, or an injection around one of the nerves in your back, as we can see on the MRI scan which one's affected, can be very effective at relieving symptoms. A third of patients say it doesn't help, a third of patients say it works for 3 or 4 weeks, and a third of patients say it's sorted their problem out and they're delighted. So it's definitely something to consider if you're in a lot of pain. And surgery here, there's not such a long list, and if you are in real trouble, you're not getting better after a couple of months, you've tried the above, or if you have weakness, then an operation can be worthwhile. And the operation here is called a microdiscectomy. It's a relatively straightforward operation. If you're practiced at doing this, you're fast asleep, you lay face down, we put a needle into your back and take an x-ray so that we can see which disc we're pointing at. You then have a cut on there, which is about 1.5 inches long, and we use an operating microscope, and hence it's called a microdiscectomy. Microscopes are great because it means you can get lots of light going down the hole. You can connect a TV camera to the side so that your assistant can see what's going on and the nurses can see what's going on. You can zoom in and magnify things. And although this is a picture, this is effectively the view you get. And the hole that we make actually in the spine is probably not much bigger than my thumbnail, but through there we can see the nerve and the fragment of disc which has come out, and effectively the operation is to take out the bit of disc that's come out. Sometimes there's a eureka moment, and you pull out a fragment of disc like this. It's an absolute pleasure for the surgeon. You feel as though you've cured the patient just by putting that out, and the vast majority of patients wake up and say afterwards, thank goodness that pain in my buttock and leg's gone. It's one of the few operations where patients don't say to you, oh, it's terribly bad where I've had the surgery. They're just so pleased to be relieved of their leg pain. There is a drive to do these operations through smaller holes. I have to say I've tried it, my colleagues have tried it, and we've actually moved back to the conventional one because we haven't found this to be of any great advantage. Claudication, one of my favourite subjects. I've nearly finished now, you'll be pleased to know. Spinal claudication is a symptom where when you are standing and walking, you develop pain in your back perhaps, but in your buttocks and going down your legs. And this is due to compression on the nerves in the lower part of your back. If you just get the problem when you're walking, but you're fine standing, it's probably your arteries have furred up, and you're not getting the blood supply. And when you stop because you're not using the oxygen, or you don't need the oxygen for the muscles, the symptoms get better. But if the problem is in your back, then you develop the symptoms when you're standing and walking, and when you sit down or lie down, everything gets better. And if you lean forwards, it tends to get better. So I have this interesting situation. I'm sure Kate and Ollie have seen patients like this, where I see husbands and wives who come in, and they will say, well, the lady will say, my husband, in the morning he can play golf, 18 holes of golf, he's absolutely fine, and he has a drink on the 19th, and then we go out, and I pop to John Lewis and take him round the shops in the afternoon, and 5 minutes he has to sit down. I said, it just doesn't make any sense. I said, well, actually, the thing about this is when you're playing golf, you lean forwards and it opens up the space for the nerves in your back. You can easily get the ball out of the hole, and they're fine when they're sitting. But most men, when they go to John Lewis, tend to walk around John Lewis like this. And in that situation, you're upright, you arch your back. And if you wouldn't mind popping on to the next one, what happens is that the ligaments in your back, which are one of the other areas that I'm afraid can wear, the ligament in your back buckles and becomes sort of slack in that situation like this. And when you lean forwards, it stretches and the pressure comes off of the nerves. So this gives a very typical situation or symptoms that are brought on by standing and walking, and within a few minutes of sitting, they're relieved. If you've had insidious onset of your symptoms, it's crept on over a number of weeks and months, surgery tends to be the only option. You don't have to have an operation, but I'm afraid, with no disrespect to Kate, if it's progressive, physiotherapy tends not to make any difference, chiropractic doesn't make any difference. If it's come on suddenly, it can get better over a period of time. And just to move on a bit further. And just a last bit, because I know this is topical at the moment, about surgeons and picking the right surgeon, and what surgeons are up to and how we're being monitored, which I think is very important. Since the Harold Shipman issues in Bristol a number of years ago, appraisal's been brought in, and that's where, which was remarkable, we didn't have it before, where we have to meet on a year basis and assess how we've got on and make plans for the year ahead. And after every 5 years, we have to hand all that information for the GMC to agree that they're happy for us to carry on. But there are different ways of monitoring surgeons' performance. One is how many cases they get through, how many patients they see in outpatients, and you can imagine hospitals can be quite excited about that because they like surgeons, particularly in private hospitals, who perhaps do lots of operating or see lots of patients. And doing lots of operating, seeing lots of patients isn't necessarily a positive thing. It may be that you're not operating on everybody you should operate on, you're over-operating, or it might be you're under-operating. So activity is difficult. We have other things to look at, is length of stay. So how quickly do your patients go home? Patients go home quickly, generally speaking, that's a good thing if the operation's been uncomplicated. Patients going back to theatre within their admission. So if you've got lots of patients going back to theatre, that's not supposed to happen, that's a concern. Patients coming back in within a month, perhaps you've sent them home too early. Infections, if you've got tumours, have you been cured, recurrent survival. Interesting more, we have to do 360 feedback, so we have to get feedback from patients, from our colleagues, from the nursing staff, theatre staff. But one that's particularly important now are what's called patient-reported outcome measures. And I suspect, I may be wrong, but if you see Kate, she might give you a questionnaire asking you about your symptoms when you arrive, and you may get a questionnaire when you leave, so that we can demonstrate how well our intervention has affected your recovery. And if you just go on to the next slide, recently we've had something called the British Spine Registry. It's a national database of patients that have spine procedures. And we put on the database patients' normal demographics, age, date of birth, what's on their scan, what we do to them. And they're sent an email asking a series of questions about their symptoms before we do an operation. It then sends the same questions at 6 weeks, 6 months, and a year afterwards. So we get the patient's view of how well they've done with the surgery, not the surgeon saying it all went very well, everything was fine, and the patient thinking, well, I wish I'd never had the operation. And this is anonymized. Patients fill in the answers themselves. And the great thing about it is that it produces two sets of results. One is your own individual patient group and how well they've done, but it also gives an average for the database. So the thousands of patients on the database, you get an average. These, I'm pleased to say, are my results. I'm blue and red is the average. The top results, the higher you are, the better. So the columns on the left are before surgery, and the columns middle and right are at 6 months and a year. The main ones, or simplest ones to understand here, is that my patients had a similar-ish amount of back pain before their surgery, and compared with the average, not the worst, but compared with the average, patients were better. The patients that had sciatica had leg pain on the right-hand side. You can see very similar prior to the surgery, and compared with the average, it's 6 months and a year, significantly better. This is something we can't influence. The patients give this feedback, and much of it is not so much about me as a surgeon and how I do the operation. It's actually making sure you choose the right patients for the right operation. Because if you don't have the right problem, you don't have the right scan, you're not going to do very well with an operation, whoever does your operation. If you wouldn't mind going on. This is something called an Oswald Street Disability Index. So this is a measure of how much your back is interfering with your day-to-day life. And again, the lower you are, the less it's interfering with your day-to-day life, and the results before surgery, 6 months and a year. So the take-home message from me, certainly from a back pain point of view, and sciatica, MRI scan is without doubt the most useful investigation. You need to be guided on whether you should have one of those by your GP, by the physiotherapist, or potentially by myself. Most people, certainly with back pain, don't need to have an MRI scan in any hurry. Most back pain gets better with physio and painkillers. Surgery is sometimes necessary, but it's definitely the last option if back pain is your main issue. Most sciaticas will get better spontaneously. Physio, injections can be worthwhile. Surgery is a modest operation. It's usually very effective. And if you're not settling after 2 or 3 weeks, then I think it would be reasonable to say that having an operation at that stage is not unreasonable. And finally, I've said you have to be very careful of what they say in the Daily Mail health section, and to sometimes take it with a pinch of salt. My daughter found this cartoon on the internet, and I particularly like this one, not just because it keeps going round, but because sometimes things are not clear. But certainly from a surgeon's point of view, if you have the right problem, the right patient, the right MRI scan, everything fits together, and you do an operation, then you're likely to get a good result. As soon as things don't stack up, they don't make sense, then you need to be cautious, because you're far less likely to get a good result. And certainly for most of us with that British Spine Registry, we want to have good results, and therefore we want to make sure we choose the right patients to operate on when necessary. Thank you very much. That's it. Thank you.
Well, thank you very much, Spencer. Thank you very much, Kate, and Karen sat at the back. I hope you all found that pretty informative. Does anyone have any questions or anything they want to ask as a result of what we've talked about? Because there's been a huge amount of information, and possibly raised more questions than answers for you. But if there is anything you want to ask, then please, we are your panel for as long as you hold us hostage. If not, then have a good evening, and thank you very much for coming. But yes, first question.
If you recently, my girlfriend's father had an operation, and he went privately, and he's like looked through all the data for the surgeons and was like, this guy. And can you do that on the NHS, or do they? If like obviously you now we've like, well, I heard a talk by this guy and I want him, so like you know.
Well, I don't know actually, because this data on the British Spine Registry, to the best of my knowledge, isn't available to the public. That will be in the future. Yeah. The cardiothoracic surgeons do have a database where you can look up your cardiothoracic surgeon and see how good they are. Some is it's slightly easier because they have relatively few operations, the cardiac surgeons, so you can look at that. I'm not sure where, private or NHS, you can look up and be absolutely clear of surgeons' outcomes. There's a real drive at the moment, certainly locally here in the post-Patterson era, that private hospitals throughout the UK are being asked to make sure that they publish surgeons' outcome data. Some of the data is not necessarily that helpful, but as I say, length of stay, return to theatres, readmission, necessarily with certain operation types give you a good idea of how good or bad that surgeon is. There might be an indication there, but I'm not quite sure with a spinal surgeon. I would know where, for myself or one of my colleagues, to look up where I could say, yes, they're definitely the man or woman for the job.
I guess it's like, I'm not at that stage yet. I'm actually, I think I'm going for a scan.
Yes.
And I'm at the end of like the physio treatment sort of stage. And so, but I guess if I did get there, it would probably cause me quite some anxiety thinking, it's just a lottery then. What if I get someone that's not particularly good?
I think that is, and then you have to, often there's a relationship relationship built up with GPs and physios, with surgeons who they gain confidence in, and so I think you definitely should ask around, not just take an opinion from one person as far as who you should be going to see. Once you've had an opinion from a surgeon, it's not unreasonable to ask for a second opinion. I don't think that's unreasonable.
The other slight anxiety, I guess, I had, like, I mean, I don't know what they're going to do once, or what they're going to see once they've had this scan, obviously. But I just thought, well, my perception of it is that the NHS is so cash-strapped that they'll just go, well, can you walk? Are you in absolute agony? In which case, we won't bother really dealing with it, and it will just degenerate until, I can't walk.
I think the timescales are sometimes different in the NHS. Now, I have to say, for the acute things, if you have problems with your bladder and bowel, if you have foot drop, then the NHS is pretty good at sorting you out. If you present quickly, you will be, we could be doing an operation. I'm on call later on tonight, and if you went into the QE at 10 o'clock this evening with the problems just come on, you would have an MRI scan. You'd either have your surgery at 8 o'clock in the morning, or depending on your symptoms overnight. So for the acute things, the NHS is good. Certainly, having been a consultant for 21 years, I would want to do, and do in the NHS, what I do in the private sector. And I think the vast majority of spinal surgeons would feel that that was the right thing to do. Clearly, if you're a plastic surgeon, what you do in the private sector and what you do in the NHS are going to be different. But for a spinal surgeon, I certainly, and I think my colleagues, the majority, would do in the NHS what they do in the private sector, but it might be that you can have it a bit more quickly. Yeah. And it might be that the consultant does it as opposed to the trainee.
That's reassuring, because at this stage, like you said, it's mostly physiotherapists, but I haven't spoken to any spinal experts or anything like that. So
but the physiotherapists, in fairness to their job is slightly to be a gatekeeper, but they are aware that although it might not be transparent, they're thinking when you come into the room, they're thinking red flags, cord recliner. That is their job and their expertise, to filter out patients that need to be referred on promptly, that do warrant an MRI scan at an early stage. And all of the questioning that Kate's referred to is part of that process.
I've had a back problem for about 30 years and used lots and lots of osteopaths and physios. And if it's any help to the gentleman that asked the question, what I did, I kept asking advice from the osteos and the physios to who would be best to be referred to. And ironically, I was referred to your clinic.
Right.
It gave me the, shall we say, the support that I think I needed at that time and all the rest of it, because the initial problem would have been an operation. But the osteopath that I was suggested, well, that might not be the best option. But if you go, I suggest you try this clinic, and one of your colleagues examined me, and I had the MRI scan. And the option was, don't do anything. Just leave it. If you can manage it, then that's the best option. So the advice is that just ask the people that are around you, and then you will probably be directed to where you want to go, rather than accepting the first thing that is...
I think looking on the internet is terribly difficult. Finding that sometimes the people that do the most advertising on the internet is not necessarily the greatest reflection of whether they're the best opinion.
Yes, again, it's really hard to
it is
find
difficult.
anything on the internet, and obviously the GP isn't a specialist, and the physio obviously know about their area and rehabilitating. I've looked into a lot of stuff like the hip flexors. I know I've got tight hip flexors, and I know my glutes probably aren't as strong as they could be.
I think the surgeon part, though.
Area that
but I think
I'm feeling in the dark about.
But I think the physiotherapist and also and your GP will have a feeling for whether they think, if patients are referred up, then Ollie, Kate, Karen will be thinking, I'm not expecting Mr. So-and-so to end up with an operation. And if Mr. So-and-so is encouraged to have an operation, then over a period of years you start to think, is that so I think if people have been in the area for a while, they generally have a pretty good idea of who they feel that they can trust.
And don't forget, once you have the scan, scan, and if you then go on and see a surgeon, that's your opportunity to ask all of those questions in absolute detail, and that's all that, that's that opportunity, isn't it? So don't think, you have your scan and then that's it, you're sent off to a surgeon to have surgery against your will kind of thing. That's your opportunity to chat it through with them and look at the MRI scans and see what it shows and what that means.
I guess again, it's like the anxiety, the perception that the NHS is really cash straps. It's like when I'm talking to the physio and they're saying, how are you this week? And you're thinking, do they just want to get rid of me? And they just want to get me out of this process. And I guess you're seeing that flow chart, the algorithm, sort of helps explain what they're seeing, and they're obviously going back and looking at that and thinking, okay, he gets through this stage and he goes here, and just having that knowledge was helpful.
Yes.
Whereas you're not privy to that.
Yes. Yeah.
I think there's a wealth of information out there, and I've been a local GP in the Solihull area for over 10 years now, and we kind of don't have the same data that Spencer has to look at his own performance, but we have a pretty good clue about who's good, who's not good, and so will the physios, because they're picking up the pieces afterwards. So actually, you don't have to necessarily go to the surgeon specifically to ask those questions, but speaking to the people that are trying to help you in the initial stage should be guiding you in the right direction and helping you make those decisions. And whilst I'm not a specialist, as you saw, 40% of patients off work have back pain, or it is because of back pain. Back pain forms a huge part of my daily job. So if I'm not pretty clued up on it, then I'm not really doing a very good job. And as Spencer has alluded to, we're kind of front line. So we're the people that triage, that assess where we go. Of course, sometimes doctors will drop the ball. Surgeons will drop the ball, and that's, we're measuring statistics after all. So there will always be those patients that you miss and don't see. But we do have a lot of experience in knowing the local health services, be those private or NHS. And as Spencer said, he works both privately and in the NHS. And so you're going to get the same decisions being made regardless of which environment it's in. Often the biggest difference is just the speed at which that can happen and the level of service, personal service, that you receive. And those are the two differences I see between private and NHS. You should have the same operation performed by the same surgeons for the same reasons, be it privately or NHS.
That's reassuring. That's one of the reasons I came here, was thinking, I just wanted to see how much it costs privately or what the options and stuff like that.
Can I just also say, when it comes to the physio side, in the NHS, you are a little bit restricted because we have the guidelines, the start back and the questionnaires, and the managers will say, well, if they score such and such, you are only allowed so many treatments. And so sometimes you have less treatment on the NHS because you are coming up as being relatively mild. So in the private sector, we can sometimes nurture and continue the treatment over a longer period of time, so the outcome is better at the end. And that's a little bit the shortcoming of the NHS, is that sometimes you are thrown back into the community a little bit too early and you're left a bit on your own.
One other reassuring thing to say is if you have private medical insurance, the insurers AXA and Bupa are very keen not to have their money wasted. So they have consultants who they prefer their patients to go to. They have huge amounts of data on conversion rates, how many injections people are doing, how long patients are in hospital for. And although it's caused some unhappiness amongst the surgeons, not just spinal but other areas, the private medical insurers are trying to direct patients to those surgeons that they think are adhering to NICE guidelines, for example, that we've. So the NICE guidelines apply to you whether you're private or NHS, and that your private health insurer, if you're going to, will be looking and saying, I don't think what's happening with this particular surgeon is adhering to that, and they will write to that surgeon or say, we're not going to recognise you, or we're going to put you right down here. So it's interesting because the private medical insurers are trying to help direct you to the appropriate surgeon as well.
Great. Well, I think we'll wrap it up there, if that's okay. Thank you all very much for coming. We host these talks every month. If there's anything of interest in the future, or if you have suggestions about subjects you'd like us to talk about or host, then please let us know. We love feedback. It helps us guide what we do in the future and how we host these talks. So please feel free to let us know what you think. You can email us. There are comment cards downstairs. But thank you very much for coming.
Thank you. Thanks. Thank you.
You're listening to Solihull Radio.